Welcome to Grand Rounds. Our speaker today is Dr. Krishna Komanduri, who is the Chief of the Division of Transplantation and Cellular Therapy. He's also the Director of the Adult Stem Cell Transplant Program and Associate Chief Medical Officer for Clinical Innovation at the Sylvester Cancer Center. Dr. Komanduri received his medical degree from the University of Minnesota. He completed his internal medicine residency at UCLA and his clinical fellowship at UCSF. This was followed by a postdoctoral fellowship at the Gladstone Institute for Virology and Immunology. His laboratory research is focused on studies of cancer immunology and has been widely published and supported by the NIH and other cancer-related foundations. Please join me welcoming Dr. Komanduri as he gives his talk on T-cell immunotherapy for cancer, advances and challenges of global implementation.
Thank you. Thank you. Thank you. Thanks, everybody. Let me try to walk around a little bit if I can. So, So the reason we're here is to talk about this, and I think all of you have, seen, the hope and the hype, and you can see this in covers of both scientific publications, Science magazine calling it the breakthrough of the year several years ago. Cover the New York Times. This is Carl June at the University of Pennsylvania, Steve Rosenberg at the National Cancer Institute, who did some of the seminal studies in CAR T-cell therapies leading to the work that I'm going to talk to you about today, but also a nice Time article, actually, which I think sums up much of, what I'll talk about today, inside the brutally selective, hugely expensive, life-saving trials of immunotherapy. And again, broad range of publications. So I think many of you understand that these are important therapies, but I'm going to try and give you a better handle today on exactly what this actually means. What are CAR T cells? What are the clinical trial data? I'm going to show you how we've actually contributed here at the Miller School of Medicine and Sylvester Cancer Center to one of the more critical trials that led to FDA approvals. And I'm also going to talk about some of the limitations of where we are in the field with respect to issues of relapse, for example, and toxicities. And then I'm going to spend the last part of the talk actually talking about two things that we don't always talk about, which are issues that are barriers to therapy. So, and I think specifically clinical challenge and systems efforts to improve consistency in grading, documentation, and management across centers. And then really the barriers to CAR T-cell implementation, including access and the unique financial challenges of these breakthrough technologies. So this is, as many of you know, Salvador Dali's painting, Persistence of Memory. And this is really the first description of immunologic memory by the Greek historian Thucydides, who was describing the plague of Athens. And he noted that there were individuals who were exposed to the plague, and yet were able to care for victims. And he wrote that the sick and the dying were tended by the pitying care of those who had recovered because they knew the course of the disease and were themselves free from apprehension, for no one was ever attacked a second time, or at least not with a fatal result. So this is really the first immunologic description of memory. We didn't learn until millennia later on that this was resident in cells in the adaptive immune system, including T cells. I'm not going to talk much about the science of how we understood what adaptive memory is and the science of memory T cells, but it's critical to what we're talking about today and how we're manipulating them. So I'm going to start with a case, and this is actually a case of a patient who was taken care of by both Joe Rosenblatt and Lazarus Lakakis, who was our first patient who was treated with CAR T-cell therapy. So I'm going to call her Claire. That's not her real name. She's a 59-year-old woman with non-Hodgkin's lymphoma who presented in November 2014 with epigastric pain, and a CT showed retroperitoneal mesenteric lymphadenopathy and a splenic mass. So patients like this with diffuse large B-cell lymphoma have 60 to 80% chance of actually achieving a remission that's long-standing, that is a cure with upfront chemotherapy. Unfortunately, she was not so lucky. So she had c-MYC positive, so MYC oncogene overexpressing diffuse large B-cell lymphoma. And for 7 months, she, instead of responding to R-CHOP, which remains the standard of care after decades of trials, got R-CHOP and failed, IVAC and failed, actually received an anti-CD37 immunotoxin, and in June of 2015, and you don't have to be a nuclear medicine specialist to realize that these black spots are areas of avid disease by PET-CT scanning. So she received salvage therapies at that point with gemcitabine and oxaliplatin, with lenalidomide, an immunomodulatory agent, and then cisplatin, gemcitabine, and ibrutinib, which is a Bruton's tyrosine kinase inhibitor that inhibits B-cell signaling, and dexamethasone. And then, I would say a last-ditch attempt at this point, she received checkpoint inhibitors that have been FDA approved in the setting of melanoma and lung cancer and other diseases, but not shown to be clinically effective as single-agent therapy for this disease. And remarkably, she actually looked clinically reasonably well, but at this point still had massive disease, including the majority of her spleen involved with lymphoma and disease surrounding the aortic arch, and there was even worry that she could erode her aortic arch as a fatal event. So the primary considerations at this point were, I think, the only reasonable things, which were hospice versus clinical trials, and indeed we were lucky enough at that point to enter into this trial called ZUMA-1, which was the trial of CAR T-cell therapy for CD19 positive lymphoma. So this is what happened. This was her prior to therapy PET scan, and in February 2016, in her first post-therapy staging, she had no evidence of disease. So this is probably more than 1 kilogram of disease, and that was gone within a month after therapy. The story does not end as happily as that. I'll come back to her story later on. So this is Alfred Velpeau, who was a French physician, and we don't do these paintings anymore, unfortunately, Dr. Weiss. So but this is what they used to do if you were a prominent physician in France at that point. They would paint a painting of your trainees around you. But this unfortunate gentleman is not the patient that I'm going to talk about here, but Velpeau is one of the first to have described, I think, what we now know to be a case of acute myeloid leukemia. So in 1825, a florist walked in and basically died within days, but had massive splenomegaly and other lymph node involvement. And Velpeau described the blood as having a gruel-like consistency, and it was that white change in the blood that later on Virchow and others termed Weisses Blut, or white blood or leukemia, which is the term that we still use today. So really, we had no therapies for the first 150 years or so, and I'm going to actually talk about how the literature evolved in this field. But we started to do allogeneic stem cell transplants for malignancies in the late 1960s and early 1970s. This is actually a seminal slide done by Mary Horowitz, who is the scientific director of the Center for International Blood and Marrow Transplant Research, and for a long time was chief of Hem-Onc at the Medical College of Wisconsin. And it was republished by Fred Applebaum in Nature and other articles. So when we started doing allogeneic stem cell transplantation, people got high doses of chemotherapy and/or radiation, with the idea that we're basically, almost really basically nuking the marrow and wiping out all of good and bad hematopoiesis. And the rationale for doing an allogeneic infusion of stem cells, which also included T cells from the donor, had nothing to do with any immunologic basis. It was indeed just to basically wipe out, effectively the bad weeds in the garden, and then coming from another individual, really replanting the garden with hematopoietic cells from somebody else, with the hope that those super high doses of chemotherapy and radiation would do what sub-ablative doses of chemotherapy and radiation could not accomplish, which is cure of the malignancy. So we recognize, I'm going to show you some slides coming up, about that graft versus host disease was a complication of this therapy. And at that point, based on murine modeling and empiric studies of humans, we recognized that T cells were actually the operative mediator of graft versus host disease. So what Mary did is she actually looked back at the registry, because at this point, by the mid-1980s, it became possible to either select hematopoietic cells or mechanically remove T cells from the donor graft, so to do rudimentary graft manipulation. And she looked at individuals who had these T cell depleted grafts, and also looked at a subset of individuals who actually had a syngeneic or identical twin donor. So these are not just fraternal twins, but actually people who had an HLA identical immune system. And she looked at really large groups of patients. This was over 1,000, actually almost 2,000 patients who were looked at across these groups, and basically just correlated clinical outcomes with how the graft was handled. Okay, so very simple clinical research. I think a good lesson for the trainees in the audience that outstanding and seminal clinical research does not have to be that complicated. So she just looked at outcomes and said, did recipients of allogeneic transplants from the registry have graft versus host disease, either no graft versus host disease or acute graft versus host disease only, or did they have chronic graft versus host disease, these curves down here, or did they receive grafts from either identical twins or T-cell depleted grafts? And what she showed quite remarkably was that if you looked at the probability of relapse in individuals who had no graft versus host disease, roughly 25 to 30% of individuals had relapse after transplantation. In patients who had chronic graft versus host disease, either with or without acute graft versus host disease, the relapse rates were half of what they were in patients who had experienced no graft versus host disease. And interestingly, when patients had T-cell depleted transplants, which aren't associated with graft versus host disease, of course, because the mediators are gone, the relapse rates were basically doubled. Okay? So that told us something that was really critical, and that's that the T-cells that were being transplanted were not only responsible for this toxicity that is graft versus host disease, but were also responsible for something good, which was the prevention or control of relapse. Okay? So that really allowed us to look at allogeneic transplantation quite differently. The second, evidence that came was the work that was done by Shimon Slevin in Israel and individuals, Bob Collins at UT Southwestern and Hans Kolb in Germany, at looking at patients who had relapsed, now recognizing that if you took out the T cells and patients relapsed more, well, what if you had a relapse? Normally, when we had a relapse and when I was a resident and fellow, if we had somebody who relapsed day 30 to 100 after transplant, which is often when these relapses occur, we would basically send them to hospice because they had effectively had high doses of chemotherapy in the outpatient leukemia setting, had an allogeneic transplant with ablative doses of chemotherapy with or without radiation. And if they relapsed at that point, we would basically do nothing more. We would often just pursue comfort care. But there were individuals who, at that point, had no evidence of graft versus host disease. And empowered with the understanding that if you take out T cells, your relapse rates increase, individuals decided, well, let's just take more T cells from the donor before we send patients to hospice and infuse those T cells alone. And this is an example of a patient who had chronic lymphocytic leukemia, who basically has increasing, who had relapse and had rituximab, so anti-CD20 therapy, with still, so this is actually the immunoglobulin quantitation. And the bottom line is the patient had infusion of donor lymphocyte infusion and at that point achieved 100% donor chimerism, that is converted over to donor cells, and the amount of abnormal, basically the amount of malignancy went away completely. Okay, so this basically showed, and similar results were actually seen in chronic myeloid leukemia patients, and to a lesser extent in acute myeloid leukemia and acute lymphoid leukemia patients, that infusing T cells alone without any additional chemotherapy in patients who relapsed early after allogeneic transplantation could result in sustained remissions. So if you look at where we were when we started with Valpo in 1825, between 1825 and 1950, there were only 1,000 publications about acute leukemia. So that's about 8 publications a year over 125 years. So we had really no curative therapies. And it won't be the focus of my talk here, but really prompted by the problem of acute childhood leukemia. And if you haven't read it, Sid Mukherjee's book, The Emperor of All Maladies, which won a Pulitzer Prize several years ago, is really a wonderful read, especially the first chapter of that book talks about the iterative use of combination chemotherapy in children with acute leukemia at the National Cancer Institute. Tom Fry and Jay Freireich did this together. And in fact, what they did was basically add on successive approaches to therapy that ended up leading to effectively a long approach to ALL therapy over a course of about 2 years that eventually led to meaningful survival, that is cures of children with leukemia for the first time. The survival rate for children with acute leukemia at the beginning of the 1960s was effectively 0, but by the end of the 1960s was 30 to 40%. And we now expect basically 90 to 95% cure rates with childhood leukemia therapy. So the combination for chemotherapy for leukemia started to cure patients with acute myeloid leukemia and acute lymphoid leukemia in the 1960s. And again, in the late 1960s, in 1968, the first successful allogeneic transplant was performed for B-cell immunodeficiency. And shortly thereafter, patients with leukemia were transplanted at the Hutch and other institutions. And by the early 1970s, we could clearly cure a subset of patients with allogeneic transplantation with acute myeloid leukemia. The problem is that chemotherapy does not persist. So if you look theoretically, when we give chemotherapy, you can basically see that what we're doing is we're giving doses of chemotherapy that go away, and we're giving it in a metronomic way. But the tumor, of course, tends to shrink. But if the tumor starts to increase again, we don't know until that disease becomes detectable radiographically. And indeed, what we're typically not doing is reacting to that until we know that overt disease relapse has happened. The difference between that and how the immune system reacts to pathogens, of course, is quite different. So we recognized, again, by the late 1960s, early 1970s, that high-dose chemotherapy with stem cell rescue could cure patients in the autologous transplant setting where there's no immunologic effect. In this case, the benefit relies on the chemosensitivity of the cancer. But as I showed you, in allogeneic transplantation, there's really a combination of chemotherapy and immunotherapy. And this can clearly cure patients with chemorefractory disease. And there's both a graft versus tumor effect that prevents relapse and graft versus host disease that reflects toxicity that we want to try to eliminate if we can. So this really understanding of the fact that there were tumor-reactive T cells that could cure patients with refractory malignancy really led us to, I think, a platform of trying to understand what T cells themselves could do alone. And indeed, we know that these T cells, unfortunately, can also cause graft versus host disease, attacking healthy tissues in the patient, but that they can cause graft versus tumor responses, which are good, and also mediate pathogen-specific immunity from donor to recipient. And I'm not going to talk about research in our own laboratory, but there are a number of things that we're doing, both to improve the recovery of pathogen-specific immunity and understand how pathogen-specific immunity functions in healthy individuals, as well as understanding how we can eliminate or limit graft versus host disease while maximizing graft versus tumor responses. So I think any of you who have seen a television ad for rheumatoid arthritis knows that those 60-second ads have 10 or 20 seconds of this is the benefit for you for your rheumatologic disease, and about 45 seconds of caveats related to all the horrible infections you can get, right? And why is that? That's because the immunosuppression that we use is very nonspecific. And I think a critical question in allogeneic transplantation is how do we harness that very potent allogeneic graft versus tumor effect that comes from transferring millions of T cells or millions of different clones from the donor to the recipient without having to know anything about the targets in the recipient, but unfortunately can cause graft versus host disease while mediating graft versus tumor responses. And that is a critical question that I think that remains important despite the successes that I'm going to show you in CAR T cell therapy. So we recognized by the 90s that T cells were critical for transplant cures, and that led us to a dramatic increase in success. Examples of successful immunotherapy, so I want to point that out, that I think that the first clear curative hematologic immunotherapy was allogeneic hematopoietic stem cell transplantation. We know that other therapies, including the use of interleukin-2, use of type 1 interferon, BCG, can be curative as monotherapy with superficial disease. I think I've lost my pointer. I don't know if we have another battery. Again, anti-tumor monoclonal antibodies can result in durable responses, typically cure rates in combination with chemotherapy. Again, T-cell vaccines, we think, like, for example, the Dendreon vaccine, Sipuleucel-T, can improve time to progression, but really has effectively vanished because of its modest effects. And then we have, again, anti-checkpoint antibody therapies, which result in durable objective responses and a plateau in survival curves in a subset of individuals. And that, as I'm going to talk to you about today, CAR T cells, which can demonstrate significant responses in refractory disease. I'm not sure if we have another pointer or a battery. So evolution in CAR T cell design. So what is a CAR T cell? So a CAR T cell is basically a T cell that, rather than having an extracellular moiety that is a T cell receptor, which recognizes HLA molecules and peptides, has basically the external portion of the T cell receptor engineered to look like a monoclonal antibody. The first generation CAR T-cell antibodies had an intracellular signaling moiety like CD3 zeta, and again had the external single-chain FV fragment that basically is the recognition domain of an antibody. The second generation CAR T-cell molecules, which form the basis of the approved products that are FDA approved today. Let's see if I can do it from here, actually. Okay, yeah, I can actually do it from here. Include. Oh yeah, perfect. That'd be great. Yeah, I can do it from here, but it'd be great to walk around. Okay. I can use that from here. Okay, I'll stay at the podium for now. Include a co-stimulatory domain, CD28 or 41BB, and the best way to describe this is that T cells effectively, to prevent autoimmunity from becoming a significant problem, require two signals. One is the antigen recognition domain through the T cell receptor, and the second is like a secret handshake. Okay, so if you want to get into a speakeasy, you knock on the door and you have to go in. You have to also say the secret word, right? So the CD28 or the 41BB is a co-stimulatory domain that adds to the specificity of the T cell receptor engagement and prevents autoimmunity from happening. And again, the CD3 zeta molecule, which would normally signal through the T cell receptor. There are third generation CARs that I'm not going to talk about today, which could include a combination, for example, of CD28 and a second co-stimulatory molecule like 41BB or OX40. And again, these are in clinical trials in various diseases. Okay. So I want to highlight a difference between CAR T cells here, again, which have the inside of a T cell receptor, but the outside of an antibody, and the way a transgenic T cell, thank you. Great, thank you so much. So a transgenic T cell works. So this is how a native T cell receptor recognizes antigen. And I think the best way to describe this is it's been described as the T cell receptor recognizes class 1 or class 2, class 1 for CD8 cells and class 2 for CD4 T cells on the surface of a cell. And actually, so peptide complexes are generated and digested and then displayed on the surface of cells in the context of class 1 and class 2. And basically, a T cell receptor recognizes something that I think is best described by crystal structures as looking like a peptide in the HLA binding groove, which is like looking at a hot dog in a hot dog bun. So imagine that the T cell receptor does not recognize the hot dog bun unless it has the hot dog inside it. That's basically what's happening. You're seeing typically an 8 to 14 amino acid peptide displayed on a binding groove in the context of HLA class 1 or class 2, and that's what's seen by the T cell receptor. So T cell receptors are important because they can recognize anything in the cell. All proteins in the cell eventually get degraded and get cycled through the Golgi to cell surface expression on class 1 or class 2. On the other hand, antibodies recognize only antigens that are already on the cell surface, so they don't recognize intracellular antigens. So this is an important distinction because CAR T cells won't recognize the broad range of proteins present in a tumor cell, whereas native T cells do. Now, there are T-cell engineered platforms that are in play and are being developed, and a number of those trials, for example, developed by a company called Adaptimmune, are in trials at Sylvester. We've treated at least 3 patients with solid tumors that are engineered T-cell receptors. The difference, on the other hand, is that T-cell receptors have to be specific for the patient's own class 1 or class 2. So they have to effectively be tailored to the patient's HLA status, where antibodies, of course, can be infused in anybody regardless of their HLA status, which allows them to be used much more broadly. Okay. So what are the mechanisms of action? So what happens so we have a native T cell, and basically when we create a CAR T cell, we're basically putting viral DNA into the cell, and that's allowing then expression of this new CAR on the cell surface. So in addition to the native T cell receptor that cell has, it now has this chimeric antigen receptor, which again has this B cell antibody-looking thing on the outside. So here's a tumor cell sitting there expressing antigen. So the CAR T cell now, the CAR now enables the T cell to recognize tumor cell antigen. For example, this might be CD19 or CD20 on the cell surface, which is a target of the therapies that I'm going to spend the most time talking about today. But the difference between this and a chemotherapy is that once the T cell meets its target, it now multiplies and releases cytokines, which we hope leads to tumor cell apoptosis and death. Okay. So the other fundamental difference between this and chemotherapy is that T cells persist and expand in vivo, or at least theoretically can do this. So if you look again at T cell therapy, when a tumor progresses, Okay, let's say a tumor responds to therapy and then starts to progress again, the T cell can re-expand basically inside the patient's own body and then act in a memory response. So this is a remarkable video, I hope it works, from Stan Riddell at the Fred Hutch, who's one of the pioneers of cellular immunotherapy. So these are actually, these long elongated cells are actually glioblastoma cells in a culture dish. The little rounded, more refractile cells, you'll see them moving around, are CAR T cells that are engineered with a CAR molecule that recognizes these glioblastoma cells. And I'm going to let this clip roll. And you'll see basically what they're doing is they're attacking the malignant cells. And indeed, as the cancer cells go away, the number of CAR T cells is actually not declining, but increasing. So you'll see by the end of this little clip, now far more CAR T cells at the end of the clip than you had at the beginning of the clip. So this is really fundamentally different because the cells can then in vivo respond to tumor progression. So what is the overview of CAR T cell therapy? So the patient undergoes an apheresis or leukapheresis. The T cells are actually typically shipped off. Obviously, if we had endogenous trials, they could be done here, but in the commercial setting and in the context of the trials I'm going to be talking to you about today, cells are transferred to a good manufacturing processes laboratory and activated and then transduced. And basically, a small number of cells becomes billions of cells outside the body. They're subject to quality and release testing, and then they're basically mailed back to us and cryopreserved. We then give lymphodepleting chemotherapy, which is basically low-dose chemotherapy that effectively suppresses the immune system of the recipient and creates some space for the modified T-cell expansion and allows them to expand more quickly. But these are typically doses of chemotherapy that would have modest to minimal effects in the patient without the CAR T-cell therapy. Okay. So the ZUMA-1 study that I'm going to talk to you about next is really, I think, a critical study that led to the approval of a product called axicabtagene ciloleucel, for diffuse large B-cell lymphoma that was relapsed or refractory. I'm proud to say that we played a critical role in this protocol. There were 21 sites across the country that were selected to contribute, and only 3 sites, WashU, Moffitt, and MD Anderson Cancer Center, ended up accruing more patients than we did, primarily the efforts of Lazarus Lakakis and the clinical research team, but all of our faculty who contributed to the care of these patients. So what did it do? It looked at patients in refractory large B-cell lymphoma who do terribly with traditional standards of care. So if you look at the SCHOLAR-1 analysis, which I won't go into detail, but basically was an aggregate of 3 large data sets that were retrospectively analyzed, the overall response rate of patients with relapsed or refractory disease was only 26%. That is, roughly 3 out of 4 patients did not respond at all to chemotherapy. The likelihood of achieving a complete response, which is really, that means that the disease goes away transiently, was only 7%. And what we know is that if you don't achieve a CR with refractory lymphoma, that you're very, very unlikely to be alive. And the median survival in this group was only 6 months in this patient population. So Axi-cel is an autologous anti-CD19 CAR T-cell therapy, and it's now approved. But in the ZUMA-1 analysis, there were 108 patients who were enrolled in the study. 101 patients got treated. And this is actually from the follow-up slide that I'm going to show you the data. But the bottom line is that the overall response rate was 82%, and the CR rate was over 50%. So again, the single-chain FV recognizes CD19. In this case, this is a second-generation CAR with a CD28 co-stimulatory domain and a CD3 zeta signaling molecule. So the study design, the patients included, so first there was a phase 1 study done of 7 patients who had either refractory diffuse large B-cell lymphoma or transformed follicular lymphoma or primary mediastinal B-cell lymphoma. These are also diseases of poor prognosis if relapsed or refractory. But in the phase 2 study, which again led to the paper that I'm going to show you, there was basically a cohort of 77 patients with refractory diffuse large B-cell lymphoma and another 24 patients with primary mediastinal B-cell lymphoma. The data cutoff was August 11th of 2018, and the safety was assessed from the 108 patients in phase 1 and phase 2, and the efficacy was assessed by investigator and central review. So this is the trial design. So patients were enrolled, leukapheresis, conditioning chemotherapy, had this infusion of axicabtagene ciloleucel or Axi-cel, and were kept in the hospital typically at least 7 days, and their first tumor assessment happened at day 28, again, with minimum of 7 days of hospitalization depending on what complications arose. So if you look at the median number of prior therapies, these are patients who had up to 7 prior therapies for diffuse large B-cell lymphoma. Actually, we treated one of the sickest patients on this study. And if you looked at the International Prognostic Index, which is an index of disease aggressiveness, 40 to 50% of patients had high aggressiveness disease. Basically, 77 to 80% of patients were refractory to second-line or later-line therapy, and a full 20% of these patients had relapsed post-autologous stem cell transplantation. So this is really a terribly poor prognostic group of patients. So if you look at the overall response rates, and again, this was published in the New England Journal of Medicine, if you look at the diffuse large B-cell lymphoma patients, 82% achieved an overall response rates, again, relative to the 25 to 30% that might have been expected with historical controls. Nearly 50%, 49% achieved a complete response, as opposed to, again, 7% historical expectation. The transformed follicular lymphoma and primary mediastinal B-cell lymphoma patients, although the numbers aren't sufficient to demonstrate this for sure, actually look like they did a bit better, with actually 70% complete response rates, with the overall response rate, the complete CR rate, being 54%. So again, this is the phase 1 data, and initial data suggested with a median follow-up of 15.4 months, so 1 year follow-up. The overall response rates actually was 42%, and 40% remained in a CR. So the initial CR rate was 54%, and with 1 year follow-up published in the New England Journal of Medicine, the CR rate remained 40%. So this was again the phase 2 study that was published in the NEJ, and again this is the objective response rate, and these are patients who achieved a partial response rate. You can see that those patients did much more poorly. Progression-free survival was here, so that roughly 40% of patients were alive at a median of 15 months post-follow-up. And again, this is the duration of the response. Overall survival was 50 to 60%, though some patients had relapsed disease at the time of the original publication. So this is one of again, this is not our patient, but this is one of the remarkable images from the study population. This is a patient who at baseline had massive amounts of disease. At month 3, month 12, and month 18, remained free of disease. These are, again, normal sites where the dye accumulates during the PET-CT imaging. So this led to the publication in the New England Journal of Medicine. Lazarus was the 4th author in the study, and this led to, really was the basis for FDA approval for axicabtagene ciloleucel. So in parallel to that, the Juliet study done by Steve Schuster at Penn looked at what came up from a Novartis project, basically, and had similar results effectively. Overall response rate was 37%, CR rates were 30%. Safety was, again, something I'm going to talk about later on. There are toxicities that were very significant in both the Axicel trial as well as the Juliet trial. And this also was published in the New England Journal of Medicine in December of 2017 by Steve Schuster and colleagues. Carl Jean was the senior author. Again, this was based on the construct that was generated at Penn by Novartis and commercialized by Novartis. So Satvanilapu presented at ASH this year, so just a few months ago, an update, the 2-year follow-up and a high-risk subset analysis of the patients on ZUMA-1. Progression-free survival now with 2 years of follow-up, so a year later than the New England Journal of Medicine paper, is again at 24 months, 39%. So you can see that the survival curve looks intriguingly like it's flattening out. That is, that there are no late relapses, which again, typically in oncology means that these patients are likely to be cured. If you look at the adverse events, and I apologize that this isn't projecting, but that the 1-year analysis basically showed that 97% had grade 3 or more adverse events, and again, fever, cytokine release syndromes, and neurotoxicities are actually common. But the fortunate thing, and unfortunately it's cut off in the slide, is that basically there were almost no events beyond the 1-year landmark analysis. Okay, so the one thing that is important is that treatment-emergent cytopenias do seem to be common. And if you look at cytopenias that persist on or after day 30, any grade, 29 to 55% of patients will have cytopenias. And indeed, greater than grade 3 cytopenias, which are clinically significant, neutropenia, does persist after 3 months. in 25 to 40% of patients, and in 11% of patients beyond 3 months. And right now, George Nahas, who's our BMT fellow, and Lazarus Lakakis and other members of the group are actually putting together a report of 21 patients that we've treated in the real-world setting, 8 of whom have had significant cytopenias, and some, in fact, who have had effectively graft failure or aplastic anemia-like conditions that require allogeneic transplantation for bone marrow failure. And this is something I think that we're the first, I think we'll be the first to report this. This was presented at the Transplant Cellular Therapy meetings in February, and I think something that really bears watching. So this is data from the real-world analysis, and this is actually the number of patients with detectable CAR gene marked T cells in the blood in patients with an ongoing response over time. So you can see that at 3 months, 95% of patients have detectable marked CAR T cells in the blood. By 24 months, 2 out of 3 patients still has CAR T cells in the blood. So some of these patients are losing their CAR T cells over time, and I would also stress that this is the presence of gene-marked T cells, which is a relatively sensitive test. It doesn't say that there are large numbers of T cells or what their functional capacity is. If you look at the recovery of antibody, so these are detectable B cells in the blood that are producing antibodies, you actually see that by 9 months, 61% of patients have detectable B cells. So what does that mean? Well, if a CAR T cell is directed against CD19, healthy B cells would not be expected to recover. So the recovery of healthy B cells probably means that the T cells are probably not active enough to actually eliminate healthy B cells, which is actually a byproduct. It's not necessarily a desirable byproduct, but something that tells you that the CAR T cells are still getting rid of any cell with CD19 on the cell surface. So this actually tells us that many of the patients with ongoing responses do have healthy B cell recovery, and this is actually also seen in Steve Schuster's studies from Penn, and suggests that perhaps persistence is not as critically important. That is, you can have a recovery of B cells, which suggests that the CAR T cells aren't eliminating CD19 positive cells, and yet you remain have ongoing responses. So 75% of patients with ongoing responses actually had detectable B cells 2 years after infusion. So that, I think, is something that we need to watch also. What is the relationship and nature of persistence with respect to good outcomes? So the real-world experience with Axicell, and this is data that were presented by Jason Weston from MD Anderson Cancer Center at the ASH meeting, basically suggests that in the real-world setting, standard of care, the overall response rates and the CR rates are pretty similar to what was seen in ZUMA-1. Now, I can tell you that these patients are only about 50 to 60% of these patients fulfill the criteria that the ZUMA-1 study was required. Patients have often more advanced disease. They're often getting bridging chemotherapy, which was not allowed in the original ZUMA-1 study. And many have lab values, for example, low platelets that are, don't meet the cutoff, or slightly elevated, creatinines, for example, with mild renal insufficiency, are examples of the kinds of things that are being seen in the real-world setting and are being offered because of the dramatic advances relative to prior therapies. So again, toxicities, if you look at toxicities in the real-world setting, are pretty similar to what we saw in the ZUMA-1 study. So it suggests that this is not something that was just confined to a highly restricted patient population in the ZUMA-1 study, and then at the real world that this is not having effects. And when we've looked, again, casually at small numbers of our patients, they seem to be having roughly the same response rates, despite the fact that they're a significantly sicker population than what was seen in ZUMA-1. So again, this is an example of one of the dramatic images. Don't get tired of showing these images, shown by Jason Weston at the ASH meeting, a patient with massive disease who got standard of care Axicell, and then had, at 1 month, complete disappearance of disease. So again, imagine this, kilograms of disease literally melting away within a month after therapy. So conclusions, basically based on the 2-year follow-up and real-world experience, at the median follow-up of 27 months, patients continue to benefit from Axicell. I didn't show this to you, but they also did now an analysis of patients with aggressive lymphoma subtypes. They include double expressor and high-grade B-cell lymphoma subtypes that would be expected to do more poorly with chemotherapy. And these response rates were actually very similar to those achieved in patients with lower risk disease. So high rates of durable response rates, 48%. The late onset adverse events were largely manageable infections. There were no late onset related cytokine release syndrome neurotoxicities or deaths. So the evidence of B-cell recovery and decreasing gene-marked T cells suggests that persistence may not be required for long-term remissions, but clearly there are long-term curative approaches, and that, again, roughly 39% of patients are alive and well at 2 years after therapy, which is, again, dramatically different. I'm not going to focus on ALL today, but this just shows you a summary of the Eliana study, which was the single-arm, global-arm study with centralized manufacturing of Tisagen Leqlucel, which led to the approval of the FDA product that we now know as Kymriah from Novartis. Again, a study that was done in European centers in Australia and the United States and Canada. And again, the response rates here were also dramatically better than what would be expected in refractory ALL, which also expresses CD19. The overall response rate, CR plus CRI, was 83%. And again, roughly 30 to 50% of those patients appear to be alive and well and likely cured with CAR T-cell therapy. Though many of those patients, 30 to 40% of patients, went on to having an allogeneic transplant because that was the prior standard of care. And there are, I would say, conflicting data that are emerging about whether patients who achieve a remission to refractory lymphoma, at least in children, might actually do better if they undergo allogeneic transplantation. Data from the NCI, where some of the clinicians took patients to allogeneic transplant and some patients did not, suggests that the cure rates and the plateau of the survival curves is better when patients were taken to allogeneic transplantation, which of course has significant morbidity and mortality. So I think sequencing of these therapies, especially for pediatric ALL, is something that we don't quite know yet. So this is Emily Whitehead, who was the first patient who was treated by Steve Grupp at Penn when she was recovering from therapy. This is Emily when she was 5 years cancer-free. She loves to post these things. She actually now and her parents have a foundation where they're focusing on CAR T-cells. Emily got to visit Barack Obama when he was at the White House. This is his excuse note that says, "Please excuse Emily from school. She was with me." She's been a really remarkable spokesperson and somebody who's done amazing things. So again, in October of 2017, we were very proud ourselves, given our contribution of almost 10 patients to that trial. FDA approved CAR T-cell therapy to treat adults with large B-cell lymphoma with both a product from Kite Gilead as well as Novartis. So other commercial CAR T-cells that are being developed include the Juno product, JCAR017, which is being assessed in the Transplant trial, and again, Tisagen Leqlucel, which is being assessed in other settings. I just want to point out some of these things, for example, that the dose levels are sometimes done per kilogram and sometimes done in fixed doses, sometimes done in split doses. The chemotherapy is somewhat different in these different trials. The allowability of bridging therapy is different in different trials, and the grading of toxicities was actually different across different trials. So if people try to tell you, well, on the basis of these different products, that one product is better than the other, be very, I think, skeptical about that, because we really don't have any randomized controlled trials, and indeed many of the fundamental design elements of these trials was actually different from study to study. So we have the approval of engineered T-cell therapies, and again, this is Emily, and I think that just shows the again, approval improvement. This is actually that survival curve in pediatric acute leukemia from the beginning of the 1960s to now, just to show you how much we've made with just conventional chemotherapy, but obviously with allogeneic transplantation, we've seen dramatic improvements. So these patients are very clinically complex. It's a potent therapy, but associated with really unique toxicities. So cytokine release syndrome happens in more than half of patients. And there's also now something that's actually been renamed immune effector cell associated neuropathy, which is, neurologic syndrome, which was initially called CRESS, or CAR T-cell related encephalopathy syndrome, which is associated with severe toxicities, including aphasia in up to 30 to 40% of patients who actually receive these drugs. And in some cases, frank encephalopathy or seizures. Our first patient actually went into what really looked like a coma and was in a pseudo-seizure state for several days. I think Drs. Lakakis and Rosenblatt and I spent a lot of nervous days reassuring ourselves as much as reassuring the family that this would pass, and it fortunately did. 50% of patients require ICU management. Fatalities have occurred. We've had deaths due to both massive pulmonary embolus as well as due to cerebral edema. And again, a multi-department infrastructure is critical, including close coordination with neurologists and especially our ICU teams. So I just want to spend a minute talking about grading scales. And again, just to show you how complex it is, Trey Lee now at the University of Virginia, but when he was at the NCI, developed this NCI consensus toxicity scale. Penn individuals developed a toxicity scale, and you can actually see that they're quite different. Here, hospitalization led to grade 2. Here, it was hypoxia responsive to less than 40% oxygen. Here, again, dramatically different grading depending on which scale you used. I was actually involved with an effort at the MD Anderson, with individuals at the MD Anderson Cancer Center, developing a CARTOX scale that was published in Nature Reviews Clinical Oncology. This is yet another scale that was competing with the first two scales. So to kind of cut through this, I had the privilege of chairing with Marcel Vandenbrink at Memorial Sloan Kettering a consensus conference where we brought together 49 experts who were actually warring in the pages of scientific journals, including the editorial pages of Nature Reviews Clinical Oncology, about how toxicity should be graded and managed. We brought them together last summer, and the American Society for Blood and Marrow Transplantation, now the American Society for Transplant and Cellular Therapy, brought this group together. We didn't accept any commercial support for this. And we brought in other stakeholders, including the International Blood and Marrow Transplant Registry, American Society of Hematology, the NCI, and individuals from Medicare and the FDA. We basically developed an iterative writing process, and Satva Neelapu from MD Anderson and Steve Grupp from Penn co-chaired the writing group along with Trey Lee, who developed the NCI criteria, and Bianca Santomaso from Memorial Sloan Kettering, who's a neurologist in this arena. And this led us to really a very practical grading scale, and I just want to show you, for example, we wanted it to be something that was very easily reproducible and not requiring somebody to look at a table. For example, for hypotension, we basically said grade 1 is no pressors, grade 2 is not requiring pressors, but having fever. Grade 3 is requiring one vasopressor with or without vasopressin and requiring multiple vasopressors. Grade 4, again, hypoxia, low flow nasal cannula, face mask or non-rebreather, or requiring internal or external ventilation. So we wanted this to be something that 7 people could come to the bedside and a data manager could look at it, and it could be very, very highly reproducible. And I think we've achieved that. This was published now in the Journal of the American Society for Transplant and Cellular Therapy, and I think will become the standard and unify these 3 toxicity scales. And emboldened by this, we're actually going to bring together the same group with some additional individuals and actually tackle the much more complex problem of management. So this is some of the CAR T-cell pipeline. There are over 400 clinical trials registered at clinicaltrials.gov. The vast majority of these are still in CD19. BCMA for myeloma is likely to come next, though recently, a year ago, everybody who had BCMA CAR T-cell therapy for myeloma looked like they're having a response. Now the majority of those patients are progressing, and so the data look a lot less exciting than they did previously. There are a lot of collaborative efforts to address barriers, and I want to talk about this. So one of the issues is actually the finances of this. So there are over 400 CAR T-cell trials, and they include these diseases, again, a lot of them in the heme malignancies, but also in diseases like pancreatic cancer and glioblastoma. Are they reaching patients? So the short answer is no. The estimate of diffuse large B-cell lymphoma patients is approximately 25,000 patients per year. There are probably 10,000 patients eligible for the FDA label, probably 5,000 relapsed and 5,000 refractory patients. We know that less than 1,000 patients have received treatment with both Yescarta and Kymriah since the FDA approvals a year and a half ago, which means that less than 10% of the patients in the United States are receiving the therapies who qualify for the FDA label. And there's likely similar underutilization rate to what we already see for both autologous and allogeneic transplantation. So that's something I want to show you next. Myeloma is an optimal setting to understand the socio-demographic disparities in transplant utilization. Myeloma is the most common disease associated with autologous transplant. Transplant is a standard of care as initial therapy, and we have New England Journal of Medicine studies from the mid-1990s and repeated in the just 2 to 3 years ago that show that the majority of patients per standard of care guidelines should receive an autologous transplant. The vast majority of patients are autologous, so therefore there's not limited by donor availability. There's a higher incidence in blacks patients and higher incidence in older patients, which allows us to look at socio-demographic disparity. And there's effectively 0% mortality. We average 1 death in every 3 to 4 years of patients treated with myeloma and autologous transplantation. So the death rates to autologous transplant myeloma are actually appreciably lower than for many standard chemotherapies that are administered by non-transplant oncologists. So this is autologous transplant utilization in multiple myeloma. And again, you don't have to look closely at these data, but bottom line is these are using SEER data, the incidence of patients who have myeloma per decade. The vast majority of these patients are all under the age of 65, even though the median age of diagnosis is 68. This is the number of transplants performed. And the bottom line is that only 1 in 5 multiple myeloma patients undergo hematopoietic transplantation today, despite the fact that it's the standard of care and associated with 0% mortality, and typically no more than 15 days of hospitalization. The utilization, furthermore, is greatly affected by age and sex. And if you look at black men and black women who have a higher incidence of disease, the transplantation utilization is roughly half. And there are more recent data that look actually at both autologous and allogeneic transplantation using county-by-county data in the setting of Virginia. And the bottom line is that if you look at Northeast Virginia utilization rates, which are close to D.C., where there's a higher socioeconomic group and where there's a more white population, are higher, and the rates of utilization in Southwest Virginia, where there both racial and socioeconomic differences remain much lower. And again, this is what we see: about 50% of the patients who are black getting, I should say, the rates of transplantation in patients who are black being about half of what it is for white males and white women. And again, so if you look at the utilization in all patients in 2008 and 2014, 20% of patients versus 31%, but if you look at Hispanic patients and black patients, the utilization using CIBMTR data are much lower. So the important thing is, and this is work done by Parmeshwar Hari at Medical College of Wisconsin, when you do treat black patients with autologous transplants, their outcomes are exactly the same. So this is not motivated by a known difference, that is, patients who are African American are less likely to benefit from autologous transplant. If you take patients and they receive a transplant, they do just as well as patients who are receiving transplants at higher rates. Underutilization of allotransplant and AML. These are 887 patients with non-promyelocytic leukemia AML diagnosed in 2007. 28% of patients received an allogeneic transplant, and over the age of 60, you can't see it, it was 2.7%. So really shockingly low utilization rates. Pat Martin, who works for Anthem Wellpoint, again, excellent insurer that insures 45 million people across 13 states. And I worked in an access group for the National Marrow Donor Program for a long time. Pat actually looked at coding data from Anthem. Out of 5,000 consecutive patients who presented with acute myeloid leukemia, 8% of those patients had data that's suggesting that they had ever seen a transplant doc. Okay? So these are 5,000 patients with basically largely Blue Cross Blue Shield plans, and less than 10% of them actually saw a transplant doc. Now, you could argue some of those patients are probably 75 or 85 and maybe shouldn't have been considered for transplant, but we are routinely doing allogeneic transplants with similarly low mortality as we see in 50 or 60-year-olds up to the age of 75. So I think the important thing is that we're not seeing most of the patients who should, and I didn't have time to go into it today, but there are a lot of biases, I think, that affect this. So referral consultation, this is a slide from the NMDP. So this is important too. So if you look at often people say, well, they're 80 years old, they're 75 years old. Well, they don't have much longer to live because they've already, have life expectancy. Well, my father's 84, and if you look at this, these are U.S. Census data. At 84, his life expectancy is still 7 years. And in fact, if you take a 90-year-old, their life expectancy is still 5 years. So this is not, overall life expectancy shouldn't be determined by a median. If you live to 80 or 85 or 90, you actually have, on average, many good years left. And I think this is important in considering what therapies should be provided to older individuals. So there are a number of factors influencing access: social, age, ethnicity, language, culture, donor availability, but that's really not an issue now. We can do haploidentical transplants and cord blood transplants in everybody right now. Economic status is unfortunately a major barrier, and obviously limited number of transplant centers, capacity limitations, and provider-based limitations. So these are all things that we need to deal with, and I think this is a slide from the NMDP about transplant, but I think this is the same thing is going to be true of CAR T-cell therapy, because disease stage at the time of transplant is the only factor under direct control of a physician, and early referral is perhaps the single most important step that can affect survival. I think this is also likely to be true for CAR T-cell therapies. So education is critical: education of program personnel, education of academic physicians. And underutilization is a major problem for both stem cell transplant and novel cellular immunotherapies, and education and elimination of access barriers will result in the most immediate impact in lives saved. Often our grand round our grand round talks are about how we can incrementally improve graft versus host disease or staging or molecular targeted therapies. The thing that we are not doing well enough, and I think all of us in academic centers are to blame, is reaching patients who need these therapies today. If we want to improve cure rates, we need to go find these patients and find out why they're not coming to our centers, whether it's a lack of access to care or because of, again, these perceived biases that are not true. So this is critical. There are a whole number of elements, including social services, cell manufacturing, laboratory assessment, that all have to coordinate to make CAR T-cell programs effective. The last part of my slide, just a few more slides, relate to the financial challenges. Yep, okay. So durable therapies are quite different because there's a massive payment up front as opposed to a gradual payment over the course of therapy. So oncologic therapies cost on average $120,000 per year, but here there's a massive payment up front and then no payment beyond that point. So what we're looking at actually, so what is value? Value is really the change in benefit over the change in cost. Okay, so it's not a fixed value. So CAR T cells have unprecedented results with unprecedented costs. So the price of both Kymriah and Yescarta are $373,000 for the cell infusion alone. That's cells only, not related to any of the care that's being provided. NICE, which is a UK government analysis, and ICER, which is the Institute for Cost Effectiveness Research, and I was actually one of the two outside experts for this panel, have suggested that childhood ALL therapy is very well within a reasonable value, and it sounds callous, but you can actually say that if the cost per quality adjusted life year saved is $150,000 or less, that's assessed as having value, while NHL therapy is at the upper limit, and it's important to say that this was done really before any real world data. So currently reimbursement is not site agnostic, that is outpatient reimbursement for Medicare is actually higher than inpatient reimbursement, and the costs are generally independent of outcomes. So what happened to our patient? Well, our patient has relapsed and then underwent an allogeneic transplant and then has relapsed again. So this is important. Patients presenting with lymphoma eligible CAR T cells, some will have no response, some will have a sustained response to CAR treatment alone, but some are bridged to curative allogeneic transplant, and some are going to be bridged to an allogeneic transplant that might have extended life, as in our patient, but hasn't been curative. So how does sequencing affect the financing and the milestones? So I'm actually part of a think tank at MIT for the last 3 years that's looking at the path from discovery to delivery, basically bringing individuals together to measure and model and then extend financial models to this population. And again, we have these upfront initial costs that are quite different than other therapies. So what we're looking at is basically the parallels between transplant and cellular therapy. In transplant, we typically actually receive a case rate for 3 to 6 months that actually disincentivizes us to have increased numbers of visits, for example, and we are judged for center inclusion on the basis of 1 year risk-adjusted survival. So for CAR T cells, should we have a survival plateau at 1 year or 2 years? And should manufacturers receive a payment that's contingent on actually achieving a sustained response? This is one of the things that we're modeling now. So we're doing milestone-based contracts. We're actually doing a public payer pilot. The ideal is to model the impact of a milestone-based contract on public payers, identify and evaluate the impact of Medicaid best price, look at again, Medicaid best prices on average sales prices, identify methods to track milestone, and actually working with both payers and government and private health systems to actually do this. This group has already developed a similar pilot for spinal muscle atrophy, which is a $1 million gene therapy in children who would otherwise have progressive paralysis. So I think that there are a number of things that we learn. Again, this is, I think, my last science, so that transplants provided a center of excellence. Patients our therapy is provided on a largely capitated basis. The payment is visit independent, so the costs are not proportional to the volume of visits, for example, work RVU measurements. And COE inclusion and assessment is facilitated by assessment of program quality. There's a mandatory federal outcomes database that actually reports our risk-adjusted disease-specific survival at each center, which is used by centers to keep us in or out of network, and facilitation of consistent center assessment across payers. So I'll stop there. So this is the last thing. We're moving from an era from non-effective chemotherapies to the chemotherapy era to stem cell transplantation, where we have combinations of chemotherapy and immunotherapy, and hopefully a future of increasingly effective immunotherapies that will both be for which there will be access and also financial sustainability. Thank you.
Krishna, we're very fortunate to have somebody of your caliber and somebody with your experience as chief of our transplant and cellular therapy division, and we're grateful that you're here. Because of the interest of time and the fact that there's another class that usually comes in here to use, we're going to have to ask people to come forward with their questions. But thank you for
an
outstanding grand round.
Thank you. There'll be no science.
So I have questions.
Yeah, of course. Good.
So